student, we have started JT. We have started such JT surgery lecture in which we are discussing hepatobiliary system, and we have discussed various scenarios from topics from gallbladder, and now. Today, we are going to discuss another scenario in which a 50-year-old lady complaining of right upper quadrant pain, scratching herself, change in the color of the stool, and dark color urine. These three clinical features, that is itching, clay color stool, and dark color urine, are typical clinical features of obstructive jaundice. While on the examination, the sclera was yellow, and there was tenderness in the right upper quadrant. In this diagram, we can appreciate the yellow sclera of this patient, and if there is any obstruction at the distal end of the CBD, or if there is carcinoma head of the pancreas, or if there are stone obstruct here, or if there is any ascending infection or worm infestation which cause obstruction, it will lead to the accumulation of the bile salt and the bilirubin, and the bile salt and the bile will deposit in the skin, will cause itching, will cause obstructive jaundice and itching. While when the bilirubin level increase in the blood due to obstruction, it will excrete more in the urine in the form of urobilinogen, and this will cause dark color urine. And normally the bile excrete, the bilirubin excrete to the duodenum, and from the duodenum it convert into the large intestine and convert into stercobilirubin and excrete it in the stool in the form of stercobilirubin. Now, as there is obstruction, it cannot move towards the intestine, and due to which our stool color is clay. So, what is the likely diagnosis? How will you investigate this patient? If the ultrasound shows calculi in the distal CBD, name the option to remove those calculi and step post surgery preparation. So, the likely diagnosis is obstructive jaundice. We can do LFTs. In LFTs, bilirubin will be raised, as well as ALP, alkaline phosphatase, will be raised, which will suggestive of obstructive jaundice. While for the removal of a calculi, and we can also do ultrasound. In ultrasound, we can find any stone, or can differentiate any carcinoma head of pancreas, which are the causes of obstructive CVD. We can the option for the removal of calculi are, first we can do minimal invasive procedure in which endoscopic papillotomy is done, in which an endoscope is passed through the mouth and in the esophagus, the stomach, and to the duodenum, and in the duodenum, at the ampulla of Vater, we cut the sphincter, and due to which we can easily approach the CBD and can remove stone using Dormia basket. The second procedure is basically laparoscopic procedure. Through laparoscopically, we can remove the gallbladder, because if there are stones in the gallbladder, it can cause recurrent stone in the CBD and can cause a recurrent obstructive jaundice. So we can also remove stone from the CBD through a hole, by making a hole in the CBD, and the procedure will be called as cholecystectomy. And we will place a T tube in the common bile duct, and the long end of the T tube will be drained out, will be the long end of the T-tube will move out towards the abdomen and will anastomose to the interior wall of the abdomen to drain any secretion in the CBD. If the above three minimal procedures fail, then we move towards the open surgery. In open surgery, we can move the gallbladder through a cochlear incision, which is called open cholecystectomy, and we can also give an incision in the common bile duct and can remove stone, which is called choledotomy, and will place T-tube for the drainage of the secretion from the bile duct for 7 to 10 days. We can also do open transduodenal sphincteroplasty and removal of stone. through the duodenum we can approach to the common bile duct and can cut the sphincter, can remove the stone, and again the sphincter is reconstructed. Before the surgery we will prepare the patient, and for which we will give prophylactic antibiotic to the patient to prevent any chance any infection. We will give vitamin K to the patient because due to the obstruction bile is unable to reach to the duodenum, and bile is responsible for the absorption of fats and vitamin K from the duodenum. If there is no bile available in the duodenum, vitamin K will not be absorbed, and there are some vitamin K dependent clotting factor which are 2, 7, 9, and 10. When the vitamin K is not there, liver cannot synthesize these clotting factor, due to which chances of bleeding can occur in during the surgery. We can hydrate the patient. We can give IV dextrose and high carbohydrate diet before surgery, because in the obstructive jaundice, in the liver storage function of the glucose disturbed, and we can also give lactulose to the patient. The screening test before surgeries are hepatitis B, C. We can do ECG, X-rays, blood grouping, and blood count. Blood count to rule out any current infection, and ECG to rule out any comorbidities which are contraindicated during surgery. Coagulation profile. In coagulation profile, we can measure PT and APTT. We will keep the patient nil by mode for at least 6 hours before surgery. Thank you. If you like my video, please subscribe my channel and write about your feedback in the comment section.